Welcome, everybody. We are so excited to have you back. We have a really fantastic webinar here today with some really amazing guest speakers, some new research that we're going to be sharing. If this is your first time at one of our webinars, we are delighted to have you here. Welcome. My name is Jagmeet. I am the Senior Regional Director here at CAIO, and we are an ABA agency. We provide in-home ABA services. We support children in the community, in school settings, and primarily in the home settings. We often offer these webinars on various different topics, so you can actually go to our website, which is caiocare.com, and we have quite a bit of different offerings. So talking today with some very special guests on research on autism prevalence. We also have some new topics coming up in May, having fun and learning through everyday activities and top 3 strategies to navigate challenging behaviors. All right, well, I will stop sharing my screen real quick for some very brief introductions here. Like I mentioned, we are CAIO, and this is a very, very special day for us to be able to bring to you 2 very special guests that are going to be talking about research. And with that, we'll go ahead and dive in. We have Amanda Bacon, who's an associate professor of psychiatry in the Huntsman Mental Health Institute at the University of Utah and director of the Utah Registry of Autism and Developmental Disabilities. She's also a principal investigator of the Utah site of the CDC's Autism and Developmental Disabilities Monitoring Network. In addition to overseeing a public health system for autism, Dr. Bakian's research investigates environmental, geographical, and contextual contributors of psychiatric conditions such as autism and suicide, and how these contributors interact with underlying individual level characteristics to increase risk. We also have Dr. Ann Kirby, who is an assistant professor of occupational therapy at the University of Utah. She has authored over 30 autism research articles, and she has research funded by the National Institutes of Health. Her areas of autism research include sensory processing, preparing for transition to adulthood, as well as mental health. And lastly, we have our very own Nicole Bollinghoff, who is a BCBA and regional director here at CAIO. She's been part of the CAIO team since 2017 and has worked in the field for over 15 years. She is passionate about ABA and how it can improve the lives of those she works with and their families. She has worked in schools, homes, and community settings. And Nicole has experience training staff, developing individualized interventions, and creating classroom adaptations and modifications. And with that, I will go ahead and hand it over to our distinguished speakers today, and starting with Amanda.
Great, thank you, Jagmeet and Nicole and CAIO for having Ann and me today. We're really pleased to be speaking to you all during Autism Awareness Month. So let me just get this into viewer mode. Okay, there we go. So we will be talking with you today about the latest research on autism prevalence and characteristics from the CDC's ADDM Network. To get started, just want to present a disclaimer slide, and we do not have any disclaimers to present to you today. So brief outline of our talk with you. First, I'll be talking to you about the CDC's Autism and Developmental Disabilities Monitoring Network, the ADDM Network for short. Then we'll talk about our recent findings that were reported in December in the Morbidity and Mortality Weekly Reports. There were 2 published, and I'll be focusing mostly on findings in the report on about autism among 8-year-olds. Then I'll be talking about how in Utah, over the years, we have used data that's come out of our collaboration with the CDC at ADDM Network to support policy for children with autism and families with family members with autism, as well as some of the legislative impacts that our work has had. And then I'll take my presentation down, and Dr. Kirby will speak to you about sensory features among autistic children, some of the work she's done with ADDM data. So to begin with, I'll let you know a little bit about the ADDM Network. The ADDM Network is a program funded by the CDC with the focus to understand the number of children that have autism in different communities around the US, and then to get a better understanding of characteristics of children with autism. They have a number of specific goals, and these include describing the population of children with autism spectrum disorder, comparing how common autism spectrum disorder is in different parts of the country, measuring progress in early identification of autism, identifying changes in AESD occurrence over time, and understanding the impact of autism and related conditions in US communities. So the ADDM Network was established first in the year 2000 and does the work that was sort of outlined in the last slide, work that is focused to fulfill those goals every 2 years. So they have reported on the prevalence of autism and other features of autism starting in the year 2000, every other year, and we just released our findings for 2018. Now, this is a map showing you where ADDM sites are currently in the US. There are a total of 11 ADDM sites, including Georgia, that's the CDC site. And then there's a little bit of variation in terms of the type of work that's being done in each of these sites. All of the sites participating currently track autism among both 4 and 8-year-olds. And then a subset of sites also are doing a follow-up study and looking at some characteristics of children with autism at age 16 were first identified with autism at age 8. So Utah, over here, we are a site that is conducting both autism tracking in 4 and 8-year-olds, and then we're doing follow-up work in 16-year-olds. And then this next slide, I just wanted to show you that even within the states that have ADDM projects, usually, and actually for this current cycle, none of the states are doing the work statewide. So here we're showing in green the counties that are participating in the ADDM projects within each site. So in Utah, we are doing our work in a 3-county surveillance area. And in some states, such as California, work is being done in only 1 county. This is San Diego County and so forth. So another thing to note is that in every 4-year cycle, the specific sites that participate differ. Now, another thing that I just want to point out is the general methods that are used to identify children with autism. In this slide, what I'm showing is that the methods have actually changed over time. We use fairly consistent methods in the study years 2000 to 2016, and then in this latest study year, we changed our methods slightly. So to walk you through this very briefly, basically for our first 16 years of the ADDM Network, we used a retrospective record review approach where we reviewed records from both health sources and school sources. And we looked in those records for what we refer to as autism triggers. So a statement in the record that is associated with autism, such as child does not maintain good eye contact. If such a trigger was present in the record, then we would abstract specific information out of those records, put them into a composite record, which would then undergo clinician review by a clinician familiar with the DSM-4 and then DSM-5 definition of autism, and then determine if a child met criteria for autism. Then in study year 2018, in order to be more efficient with the ADDM methodology, as well as we got a better understanding of how well communities were actually identifying autism. And we've seen over the past 20 years a real improvement in community identification of autism. Because of those reasons, we modified the approach that the ADDM Network uses to identify children with autism. Now we actually rely heavily on a community identification. So if a children has received a medical diagnosis of autism or special education eligibility of autism, we consider them to have autism. It's at that point that we then go and abstract specific information from medical and school records for those children that meet our definition of autism. And then from there, that's the information we use to then estimate the prevalence of autism and characterize children with autism. And another thing I just want to point out is, the earlier methods, the earlier methods were done because we knew there were a good number of children who met criteria for autism, but didn't have a diagnosis of autism or special education eligibility of autism. That has really changed in the last few years with improved community identification. And finally, everyone in the ADDM networks takes utmost caution with the data that is collected. No identifiable information is shared with the CDC, and we have very robust protections in place for all data that is collected. So a very brief definition to go over about what prevalence is a basic epidemiologic measure. And on the left-hand side is a very generic definition. Prevalence is a measure of the number of cases of any health outcome or any measure of interest over the total number of persons who are looked for that condition. Now, specific to what I'll be presenting today is we have estimated the prevalence of autism specifically among 8-year-old children. So our numerator is the number of 8-year-old children with autism. Our denominator is the total number of 8-year-old children in our surveillance area. So who we reviewed for autism. So here we are looking at the ADDM Network's autism ASD prevalence over time, starting in the year 2000. And what you can see here is that year over year, we have seen a fairly consistent increase in the prevalence of autism. So in the year 2000, the prevalence was among 8-year-old children was 1 in 150 8-year-old children had autism. And now in our current study year, our prevalence is 1 in 44 children. 8-year-old children have been identified with autism in the ADDM network. So that is, in terms of, that's 23 children per 1,000, or about 2.3% children. Okay. Then we also see a lot of variation in terms of the prevalence of autism when we consider the individual sites. So here we have findings from this past study year, and each site participating in the ADDM network is a different color in this figure. So like Utah is purple. Our prevalence this past year was 21.8 children per 1,000 8-year-old children that were identified with autism. So again, that's just a little bit above 2%. And then the state with the highest prevalence was California, which was approaching 4%. And the state with the lowest prevalence was Missouri, which was just under 2%, so about 1.7%. Now, the thing to note is we're seeing a lot of variability state to state, and California, this is actually the first year that they participated in the ADDM network. And if we pulled out California, that actually our prevalence decreased a little bit among the other ADDM networks to 21.8 per 1,000 8-year-old children. Or which is equivalent to about 1 in 46 children, 8-year-old children, been identified with autism. Okay. In terms of some other prevalence findings that we think are pretty important, our male to female ratio network-wide was 4.2 males for every 1 8-year-old female with autism. This finding has been very, very consistent across the ADDM network since the year 2000. Other important patterns to look at is to see what the prevalence looks like by race ethnicity. Historically, we have seen disparities in autism prevalence by race ethnicities. Network-wide, we do no longer see variability in the prevalence of autism by race ethnicity, which is a really positive finding. However, site by site, we are still finding some variability here, such as we found that autism prevalence was higher in white versus Hispanic children in Arizona, Arkansas, Georgia, and Utah. We found that ASD prevalence was higher in Black versus Hispanic children in Georgia and Minnesota. And we found that ASD prevalence was higher in Black versus white children in Maryland and Minnesota. So we have no reason biologically to think there should be variability and differences in prevalence by race ethnicity. But this provides us evidence, and we'll talk a little bit about this later, that some more attention should be paid for improved awareness around autism by race and ethnicity in certain locations. Okay. Another finding that has been fairly consistent over time is variation or differences in the prevalence of autism by household wealth or household income or socioeconomic status. So over on the left side of this slide, I'm showing you a figure that was taken from a paper that was published in 2010 that looked at all ADDM Network data and then broke down the children who are identified by autism based on household income, based on their neighborhood. So this is a neighborhood level of household wealth. And we just broke down the data into thirds. So we identified what third of household income a child's neighborhood was measured at. So here, just looking at this part of the slide, what we see is that prevalence of autism increased with increasing wealth. And this was pretty different in terms of the prevalence by wealth. Now, in 2018, this middle figure is showing what the same sort of relationship between autism prevalence and household wealth looks like. And we do not see the same step-stone increase with increasing household wealth. And then even in some sites, including Utah, what I'm showing you here on the right-hand side is you actually see a reverse pattern. So we actually see the highest prevalence of autism among 8-year-old children residing in areas of the lowest household wealth or household income. So opposite from what we used to see. So this middle figure is again, a positive finding, meaning we, again, don't expect autism prevalence to really vary based on household wealth. And so we should see that to be pretty consistent. And now, like in Utah, we're seeing even improved identification of children with 8-year-old children with autism in children living in lower household income neighborhoods. Okay, so another, as I mentioned earlier, another very important measure we have wanted to look at in using ADDM Network data is age at first identification of autism. So here what I'm presenting to you is the median age at first identification in months. So that's what's on the y-axis here from the year 2000 to 2016. So this is the number of months at which 50% of 8-year-old children were identified by autism. And we saw in 2002 that the median age at first identification was 57 months. So half the children, 8-year-old children with autism, were identified before 57 months and half after 57 months. Now, in this data only goes to 2016, but it's not that different for 2018. We are now, the median age at first identification is 54 months, so a 3 months difference. Now that's in the right direction, but maybe not as much of an improvement as we'd like to make. Just in case this isn't commonly known, the age of first reliable identification of autism is at 2 years. So there's a lot of room to drop this age at first identification. However, so this is one way that we've historically looked at age at earliest identification. We also can look at this in another way, which shows that we've actually made some good improvements. This looks at the cumulative incidence, or the count of the total number of children that have identified with autism by study year. Again, this is all 8-year-old children. And what we're seeing here is, yes, like these curves have gotten steeper over time. So 2002 is in gray, and then 2016 is in green. And we are identifying more children with autism in more recent years. This line is steeper, but it's steeper starting at a younger age. So we're actually identifying more children at younger ages, in addition to more children overall, but also more children at older ages too. So this is just an alternative way to look at it, and does let us know, seeing this becoming steeper and steeper, and this, this curve above all the other curves is encouraging in terms of improvement in the age at first identification. Then I want to share with you a slide that considers other mental health conditions among 16-year-old children with autism in Utah. We nowadays know that children with autism often experience co-occurring mental health conditions, and this gives an idea of what we are seeing at different ages. So we're seeing not only 16-year-olds, which are presented in green, but also 4- and 8-year-olds. And these are the kind of co-occurring conditions that we measured in this in study year 2018. So we are seeing depression among some of our 8-year-olds, not our 4-year-olds, at about 4%, and then 20% of our 16-year-olds with autism have co-occurring depression. 45% of our 16-year-olds have co-occurring anxiety, 10% have co-occurring epilepsy, 6% have co-occurring OCD, 48% have co-occurring ADHD, 19% have co-occurring sensory features, and Dr. Kirby will speak about that in more depth. 1% have Fragile X syndrome, 1% have fetal alcohol spectrum disorder, and then 20% have co-occurring intellectual disability. So this is Utah-specific data. And just for comparison's sake, this is a figure that comes from a publication out of Minnesota that used the Olmsted cohort, which is a cohort that was considers births between in the 1970s to like the mid 2000s, and followed up that cohort over time and identified children with autism, and then also did very thorough characterization of their co-occurring conditions. And what they have found that by age 16, so I've just highlighted this, what they found in terms of the incidence of co-occurring depression, anxiety, very similar to what we found. So about 20% or so in their study have co-occurring depression, and similarly for anxiety. And if you'll remember, we actually found higher rates of co-occurring anxiety in Utah using our Utah ADDM data. And overall, what they found is about depression, anxiety is 3 times more likely in individuals with autism than non-affected. Okay, so to summarize these findings from the study year 2018 ADDM Network, we found that autism prevalence has increased over time since 2002 among 8-year-olds. We are finding evidence of improvement in prevalence by race, ethnicity, and socioeconomic status, so reduction in those disparities that were historically present. We do know that prevalence varies site to site, and because sites vary from study year to study year, that impacts overall prevalence. There is evidence that children with autism are being identified earlier, but there's still room for improvement there. And that we are now, with our 16-year-old follow-up study, and there's more to come with that. We have one of our first paper with that's specific to our 16-year-old follow-up under that will be submitted soon to a peer-reviewed journal. There's more of an emphasis on understanding co-occurring conditions or autism, children that not only autism, but what else, autism plus. And those findings will hopefully be out soon. And then I want to just mention briefly why ADDM Network data is so important. Here in Utah, I can really speak to how the data has been used here locally. We partner with many community stakeholders, including the Autism Council of Utah and other entities that really advocate for children and families affected by autism. And our data supports a lot of these initiatives. And some of the uses include in 2013, we had the legislature passed an autism insurance mandate, State Bill or Senate Bill 57, that supports autism services for assessment and services for children with autism. And our data was used to justify the need for such a bill. More recently, we've had an autism awareness training for law enforcement, and that's just recently gotten started. And data from the Utah ADDM Project has helped try to understand how many children and adults with autism might be in Utah to help inform this training. We also have an Adult Autism Center of Lifetime Learning that was developed by the Pingree Center here in Utah, and information on the prevalence of autism was used to develop that center. We also, last year, a bill was passed called the Autism Adult Treatment Plan that supports health. It provides funding to support health services for adults with autism. And then we also have a few autism-focused charter schools, and our data has gone to support the development of these charter schools and justification for them and demonstrate need. Okay, I want to, of course, acknowledge everyone who's really helped, been essential for the success of the Utah ADDM Project, both within the Utah Registry of Autism and Developmental Disabilities, the Utah Department of Health, as well as our stakeholders and collaborators. This work would not be possible without them, and then the application of this work to support programs for children with autism and their families would not be possible without them as well. So I think that's it for me. Thank you. And I'm going to stop sharing so that Dr. Kirby can share.
Thank you, Dr. Bakian. So for the next 10 minutes or so, I will just quickly give an example of one way that ADDM data gets used. So we recently published a study looking at what we call sensory features in the ADDM network, and I'll talk about that study. I do want to thank my collaborators on the project. And I want to make a quick note on language. There's some people use person-first language, such as saying children with autism, and some people use identity-first language. For example, saying autistic children. So I, as an occupational therapist, was originally trained to use person-first language, but you may notice that now I tend to use identity-first language, and that's due to the preferences of autistic colleagues and collaborators that I work with. So since we're talking about sensory features, I just want to take a moment and just orient you to the senses. Most people are familiar with the 5 main senses: vision, hearing, touch, taste, and smell. There's 2 that are also related to movement and balance, and that's called the vestibular system and the proprioceptive system. And then there's also a sense called interoception, which relates to our internal signals, such as hunger, our sense of temperature, knowing when you have a full bladder, and things like that. So what are sensory features? There's several different words that can be used to talk about sensory differences that we see commonly among autistic people. But these are differences in perception and use of sensory input. They are not differences in what we call acuity. So for example, there is not a hearing problem, but someone may respond differently to sounds. And these were actually documented in some of the earliest writings about autism by Leo Kanner. But it's interesting that they weren't always considered a core feature of autism. But when the DSM-5 came out in 2013, this is the tool that practitioners use to diagnose autism typically. Sensory features were entered into the definition, and the way that it's written says hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. And some examples that they give are apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. So these were added as something that can contribute to a diagnosis of autism, but I do want to point out it's not required for diagnosis. It's one of several things that may be present, but is not required to be present. So there's several different types of sensory features, as were hinted at in the definition I just showed. So there is what is in essence increased sensitivity, and that's the word hyperreactivity that was in the definition, and that can be negative reactions to sounds, wanting to wear sunglasses indoors because lights are bothersome, being really bothered by things like tags in t-shirts, being sensitive to smells and tastes of foods or textures of foods. There's also decreased sensitivity, and that's what is called hyporeactivity. And that might be not responding to, for example, a child's name being called, or not noticing differences in temperature. And then there's also, there's different words for this. Some people call it sensory seeking or intense sensory interest. And that may be a child who's really seeking out various sensations. And I do want to point out that although these seem quite different, they're not mutually exclusive. So a child can, and often do, present multiple of these. And it might depend on the sense. So it might be seeking out, smells, but sensitive to sounds, or depending on the environment or other things going on, can change as well. So some researchers have proposed that these kinds of sensory features might have cascading effects on child development. So for example, if a child has decreased sensitivity to sound, they might be missing out on opportunities to learn from receptive communication. And then they might end up having delayed communication. Another example would be, if you're very sensitive to food flavors, smells, and textures, you might have difficulty eating, and that might lead to nutritional or gastrointestinal problems. So in what we wanted to do with the ADDM Network data was understand how common sensory features are among both 4 and 8-year-old autistic children. There was no research before we did this that looked at a population representative level, and that's what this data is really great for. And then we also wanted to see what other characteristics were related to sensory features. So we used the ADDM Network data for study years 2006 through 2014, and that was over 25,000 autistic children. And we had data from these various sites, some for 8-year-olds only and some for both 4 and 8-year-olds. And what we looked at in here was we wanted to know whether they presented with any sensory features. The variable that we used was just a yes or no on whether a child had any differences in response to sensory stimuli that was written about in their record. We also looked at some demographic variables, such as age, sex, race, ethnicity, and mother's education. And then we looked at other kind of functional areas, including cognition, adaptive behavior, attention, emotion regulation, and problems in eating or drinking and sleeping. So just to tell you a little bit about the sample that we had, most of the sample was 8-year-olds, 88%. Most of the sample was boys, so 81.8%. We had a spread of race ethnicity, with the majority of the sample being white, just over half. And then mother's education, a lot of people were missing on this variable, but I see about a small proportion had less than a high school education, and then high school, and then some college or more. So how common were sensory features? We found that across the whole sample, we saw 74% of the children had evidence of sensory features in their record. So that's quite high. Again, it's not required to receive a diagnosis of autism, but we expected, even though there had been no research we could use previously, that it would be quite high. And it was slightly lower in 4-year-olds versus 8-year-olds. It was interesting that certain people were more likely to have documented sensory features. So boys, white children, and children whose mothers had a high school education or more. And those with higher than a bachelor's degree were 2 times more likely to have sensory features. And decreased likelihood in their record was related to girls, children from other racial and ethnic backgrounds, and children whose mothers had less than a high school education. So that leads us to wonder why this might be. Our best sort of hypothesis is that these groups on the right perhaps are getting less thorough evaluations because there's no kind of biological reasons we would expect to see differences based on these things. So then what else was related to sensory features? We saw that adaptive behavior problems, mood or affect problems, aggression problems, motor problems, hyperactivity or attention problems, fear-related problems, sleep problems, and eating or drinking problems were all related to sensory features. So that's almost everything we looked at. But cognition or IQ were not related to sensory features when we looked at them in a model with everything together. And then we looked at how the sensory features kind of overlapped with these other things, and just want to show you that here. The blue bars are children who had a documented problem in the areas listed underneath the bars. and the percentages are of how common the sensory features were in those groups. So similar, slightly more sensory features were present when a child had adaptive behavior problems, but it's a quite noticeable difference when we see the mood and affect, motor problems, and attention hyperactivity. But all of these, we see quite a big difference between the two groups. So just in terms of some study limitations and future research, we couldn't look at different kinds of sensory features separately, which is a problem, but we have the strength of having this large data set, which was great, but we couldn't tease out hyperreactivity versus hyporeactivity, for example. We didn't have complete information on all children, so we could only work with what was available. And we're only looking at this at one point in time. So there's other kinds of studies, such as studies where you would go into a clinic to do testing and things like that, can give more information like that. And then, so just a quick review of the findings. So this is the largest study of sensory features in autism, and it helps demonstrate kind of how the ADDM Network data can be used just beyond just looking at the rates of autism. And sensory features were highly common. About 3/4 of the autistic children were presenting some kind of difference in response to sensation. But those numbers might be even higher than the rates we saw, because some children might be missed. Like I mentioned, girls, people of color, and families with fewer resources might not have might not be getting as kind of comprehensive assessments. So it's important to think about. And so there does need to be more regular screening to take into all these sensory needs into consideration. So given how common sensory features are and how related they are to other potential challenges, we really think these are an important area in need of more research and attention by clinicians. But I just want to conclude by kind of looking at this question: are sensory features a problem? I know the way that we talk about them sometimes, for example, talking about the cascading effects they could have, has this negative connotation, but sensory features are not inherently negative. And it's hard for us to tease it out in this data, but they can be positive experiences for people. They can be negative, they can be neutral, they can vary. And so it's important to kind of be aware of, but that often the challenges arise because of a negative interaction with the environment or social expectations or stigma. So a mismatch with the child's needs and what's available to them. So there's a clear need for services and supports, and without them, a child might not be set up for success. So there should be work done to understand a child's sensory needs and preferences, and not goals that change them, but to kind of understand and meet them. And I advocate to avoid restricting access to needed sensory supports or placing contingencies on them. So I don't like using them as rewards, for example. And I'll just mention, as an occupational therapist, that occupational therapists have special expertise in understanding sensory features and helping navigate children's individual needs to be able to participate in daily activities, and they can conduct assessments and provide interventions if needed. So thank you so much for participating in the webinar today. If you do want to read the whole research study, it's available for free online, and this QR code can be scanned to pull it up. So thank you so much for your time.
Thank you so much, Dr. Kirby and Dr. Bacon. You know, one thing that you just kind of closed off with there in terms of really understanding what the individual sensory need of a child is, and kind of even tying that back to Dr. Bacon, what you mentioned in terms of the co-occurring mental health conditions, that there may be some other underlying condition or experience that the child is having. And, you know, I'd love to maybe hear from both of you, and then also hear from you, Nicole, in terms of what are ways that we can really encourage providing treatment for our patients by having that individualized care and making sure that we're collaborating and we as service providers are asking questions and asking the questions that are going to be able to reach the root cause in terms of how we can support that child. Go ahead, Dr. Kirby.
Sure, yeah, as I was saying, yeah, I think that's incredibly important to figure out what, why a child might be having a negative reaction to, for example, bathing. It might be a negative sensory experience, and trying to kind of support them. Obviously, they need to, bathe, but can we kind of work to find a way to make it not a painful experience for the child and make it kind of a positive experience. And so just, yeah, I think doing a lot of that individual work is just really important.
And I'll only add that I think it can be, there are additional challenges when a child is not verbal or communicates in other ways. And sometimes that these can get expressed behaviorally when there's an underlying root cause to these behaviors. I think there are some additional tools. If our colleague, Dr. Debbie Bilder was here, she'd talk about a tool that she developed called Sources of Distress, was to try to help provide families as well as providers to understand the root causes of some behaviors. And so that it can be more personalized in terms of some of the ways to confront the behaviors or confront the source of either in some of the even sensory parts as well. So I'll just add that.
Sure, and I think I would like to share that at CAIO, I think one of the big benefits is we don't have a goal bank or a curriculum that we are pulling from. All of our goals and treatment plans are individualized with the family input and the individual that we are working with, their input as well. We really want to help them make progress that is meaningful to them. And I've worked with a lot of individuals with other co-occurring conditions, different comorbidities, things like that. And that collaboration piece is key, just like you said, Dr. Kirby, working with their OT, especially if there are sensory challenges, or working with a speech therapist, consulting with other providers before addressing things like feeding and textures, making sure that there is not another situation going on that we aren't aware of and that's outside of our scope of practice. We want to make sure we're getting that collaboration. And I think some of the most successful teams I have been on have had big team meetings, and it was a lot of collaboration going on. I worked with an individual with an additional diagnoses as well, that we had to really adjust our ABA services sometimes weekly, depending on what they could handle in the current moment, or how much we could push to continue making progress, or did we have to work on maintenance of other skills that we had at the time? And we would, we had a school team, a psychologist, psychiatrist, speech, OT, home ABA, everybody would all jump on Zoom and get together and really talk through what's effective right now and what's making meaningful progress, and where are the areas that we can, work and go to the next level with goals, or where do we need to take a step back and really address all of those individual things that might be going on at the time.
Thank you so much. And I know we're right at time, so I'm going to ask just one more question. I think, just hearing the progress and just the impact of these types of researches is just so amazing. And, you talked a lot about the improvements in terms of the prevalence that you're seeing, amongst different communities. And that's just so phenomenal to see that over time, is that we're able to really understand better. But, what are some ways, Dr. Bakin, that you can talk about of how to continue to encourage communities to participate in these types of future studies?
Yes, what's so wonderful about the ADDM network and this data is, right, it's really important to understand what's happening within a population, because there's that relationship between what's happening in a population, what's happening in the community in terms of treatment, in terms of assessment and treatment. And that's really important information. We know now, like, where disparities still exist and where there can be more of a community focused in terms of trying to provide additional services. And then when we have acquired this additional data, and then Dr. Kirby gave this great example of this was the first population-wide study that looked at sensory features in autism. Otherwise, we end up maybe some of the prior work had been done in smaller samples, very specific samples, not generalizable samples. So we don't always know that. And then really what we hope this encourages is we find a finding, it is on a population level, we need to understand it further, and that really drives other additional, more focused research that communities can participate in, they can support, and hopefully that has additional findings that really can drive more personalized either services or legislation and so forth. So it's really, I think, a feedback loop and a cycle when we have things that are happening at different levels and have different levels of involvement.
Absolutely. Thank you so much. And, I think that, like you said, these studies are an extension of further studies and, more information that we still need to collect. And just to kind of close it off, Nicole, I would love to just one last question for you is, as we're seeing these rates increase, how can we measure that individualized progress, and how can we really determine if ABA is going to be the right fit for a child?
Sure. And, while we are developing goals and individualizing them and measuring them across time, we also understand that there needs to be a more fixed method of reviewing our services and making sure we are making meaningful progress. So we use the Vineland 3 and collect scores every 6 months for all of the clients that we work with and measure those just so that we can ensure we're making clinically significant progress. Through the release of our CAIO app, families are actually able to see goal progress and get notifications when their child is meeting a goal or meeting a target within a goal, but also see that Vineland score across time so that they're reviewing and seeing that regularly and meeting with their team to make sure, is this effective and are we making progress, or would an alternate service be better suited for these needs? I've talked to families that call and inquire about services, and as we talked, it was really about tolerating specific clothing items. And I had a conversation with them that an OT may be a better provider to address this than ABA services. And while there were other areas that we could focus on and help support, if that was what was most significant to the family, then looking at a different service would have been a better option for them. But making sure, we are making that progress over time and that our services are effective and the family, that's all fully transparent to the family as well. I would just like to thank you, Dr. Kirby, for discussing and noting the person first versus identity first language and, just the changes due to what's preferred in the community as well.
Well, with that, we are going to go ahead and close. We thank everyone that has joined today. We will be making this available on our YouTube site, and so that way we can come back to this recording. But we're so thankful for you, Dr. Kirby, Dr. Bacon, to be here. Thank you so much, Nicole, and we hope to talk with and connect with everyone soon. Thank you.